Welcome back. Today we'll be discussing Chapter 31, which covers environmental emergencies. This is the end of the trauma section. It does cover quite a bit of material, so we have a lot to unpack here, but it's relatively fun. Some of it doesn't apply all too much to New York State, but there is a little bit that we might see in all aspects of this chapter. So it is important for us to know every bit of this, even if you think that when are we ever going to encounter a rattlesnake in New York State? It can happen. So that being said, let's dive in. So we'll start off with doing exposure to cold, then exposure to heat. We'll go into water-related emergencies, and then bites and stings. So there's 5 main ways that we can lose body heat. First one is conduction. So that's direct contact with your skin. If you go into a lake during the summer, that's how you can lose body heat, is the conduction of direct contact of water against your skin. Next is convection. So if you think of like a convection oven, that's where air or water will carry away heat. So we have wind chill, so the wind kind of coming across your skin is what's going to take away heat via convection. After that, we have radiation. That's where the heat is picked up by surrounding air or water. Next is evaporation. That's when we perspirate, and the evaporation of our sweat will make us lose body heat. Keep in mind that pediatric patients don't have nearly as good of an ability to sweat. Until around age 7 is when you fully get that ability to be able to sweat. And then respiration, when we are breathing out, we can lose heat that way. That's why when you go into a cold atmosphere, say you walk outside in New York State in winter and you breathe out, you see this water vapor cloud. That's you losing heat through exhaled air. So right here's a little diagram kind of showing how body heat can be lost via all these methods. So we get concerned with cold-related emergencies because we can become hypothermic. Breaking down the word hypothermic, hypo is low and thermia is temperature, so that's low body temperature. Mild hypothermia happens to nearly everyone, but it can progress to become more and more severe to where the body is completely unable to maintain proper core temperature, which can lead to death. There are a few things out there that make you more susceptible to hypothermia. Injuries can make you more susceptible to hypothermia, especially ones that compromise the skin, because skin is one of your best thermoregulation organs out there. Chronic illnesses or other conditions. So if you have a chronic illness that makes you not have as much body fat, that can cause you to lose heat very quickly. Geriatric and pediatric patients, we'll get into that a little bit later as to why they're more susceptible. And then overall low levels of body fat. Our body fat helps insulate our body, and that will help keep our heat inside our core. So if you don't have enough body fat, you can become susceptible to hypothermia much easier. Other things that can interfere with thermoregulation: alcohol ingestion will interfere with thermoregulation. It makes you not feel as cold as you really are, so you don't get the warning signs of hypothermia. Overdose or poisoning can have the same effects. Major trauma, like I said, if we affect the skin, that can affect our thermoregulation properties. Same with burns. And obviously the decreased ambient temperature. If you are in a cold environment, you're much more susceptible to hypothermia. So like we said, geriatrics and pediatrics are much more susceptible to cold environments. The effects of cold temperatures are usually pretty darn quick with older adults. You'll see in your careers when you go to a elderly facility, half the time the apartments that the geriatric people live in are very, very, very hot. They keep them at 80, 85 degrees, and that's because they become very cold very, very quickly. Now this is fine if the patient can afford to keep their heat on that much, but a lot of older citizens have very small fixed incomes, and so they can't afford to heat their houses properly. So this can cause geriatric patients to be in a constant state of hypothermia during the winter months just because they simply can't afford to heat their own homes or apartments. And pediatrics have large skin surfaces in relation to their total body mass. They also have very little body fat, which both of those make them very susceptible to hypothermia. Additionally, pediatrics can't shiver nearly as well just because they don't have the muscle development to continue to shiver. What shivering is one of our body's main mechanisms to keep us warm, is to actually make us move and generate heat by moving. And pediatrics have a hard time doing that just because they don't have developed muscles yet, especially the very young pediatrics. So going into the progression of hypothermia, we have 3 different types of hypothermia. We have mild, moderate, and severe. So mild hypothermia starts at 95 degrees Fahrenheit and it goes all the way down to 89.6 degrees Fahrenheit. And that is from a core body temperature reading. So this is getting body temperature via rectal thermometer. So some signs and symptoms you'll see at mild hypothermia: you'll have shivering, because that's your body's way to compensate to try to generate more heat. You'll have fatigue, loss of fine motor sensation and movement. So usually they're going to be shivering so badly that they can't focus their fingers to do fine motor sensation or movement. You might start to see some altermentation, pale skin, and tachycardia and tachypnea, which is your body compensating for the low temperature. It wants to circulate the warm blood around faster to try to warm your body up. Going into moderate hypothermia, which covers a core body temperature of 89.6 degrees Fahrenheit all the way down to 82.4 degrees Fahrenheit. This is where you stop shivering. So that's one of the big telltale signs. Is mild, you're shivering; moderate, you stop shivering. This is where you have complete loss of motor control, so you have a very hard time controlling any movements. You become cyanotic and hypotensive. You have very severe altermentation. Oftentimes these patients become unconscious. And this is where you start to see dysrhythmias. The heart is very, very, very sensitive to cold temperatures, and so you can easily go into a dysrhythmia, and it can go into a lethal dysrhythmia. If you get below 82.4 degrees Fahrenheit, that's considered severe hypothermia. You'll have profound hypotension, you will have coma, you'll have pulmonary edema, and this is where people arrest. It's very hard to maintain any sort of life with a core body temperature below 82.4 degrees. And depending on the patient and how susceptible they are to body or temperature changes, they might not get to the severe hypothermia level based off of the temperature. They might just get to the moderate temperature range and go into cardiac arrest. So these are very serious patients. These are patients that need immediate treatment if you find them and their core body temperature is in these degree ranges. So when we have someone with hypothermia, we have passive and active rewarming techniques. Typically, passive rewarming is our go-to. We only do active rewarming in very certain circumstances. So, active rewarming. There's a specific way that we do this. So you wrap the patient in warm, dry blankets and maintain a warm environment. Make sure you cover the patient's head. We lose a lot of body heat to the head. It has a lot more surface area than we really think about, but the entire head covers about 18% of your body surface area. So keep the head covered because you have a lot of very delicate skin, a lot of areas where capillaries are up against your skin, and so you have a lot of heat loss that way. After you do that, that's passive rewarming, we then go and we place hot packs in the patient's groin, their chest, and their neck, especially the lateral chest, so the armpits, the neck, the groin. These are all areas that we have, again, a lot of surface circulation to where your blood can pick up the heat a little bit easier and carry it to the rest of your body. So we only actively rewarm an extremity if you have the following things intact. So only do this if the anticipated time to the hospital exceeds 1 hour. So if you are less than an hour away from the hospital, do not actively rewarm the extremity. Let them do it. Only do it if the patient presents with early or superficial local cold injury only. And we'll go over that in a couple slides. And then only do it if there's no concern that the extremity will freeze again. So only do this if you know that you can put the patient in the ambulance very quickly and get going to the hospital so that they aren't exposed to the cold for an extended period of time again. The actual procedure for active rewarming is you immerse the affected part in a warm water bath. So that's water over 105 degrees Fahrenheit. You don't want it too far over 105 degrees Fahrenheit because you don't want to burn the area either. Continue to stir the water, making sure that it stays over 105 degrees Fahrenheit. Continue the immersion until the extremity is soft, as well as color and sensation return. After you've done that, dress it with a dry, sterile dressing, making sure to put dressings between the fingers and the toes. You don't want anything forming together after something's been rewarmed. In cases of extreme hypothermia, the patient will be unconscious, and most likely will not have vital signs that you'll be able to assess. The heart rate can get very, very, very slow. It can go down to 10 beats per minute. If you do not feel a pulse, start your normal CPR with an AED. If there is a pulse present, and again, the heart rate can be very, very, very slow, then just do your standard unresponsive patient care with the caveat of be very gentle with patient handling. If you have someone who is extremely hypothermic, if you handle them roughly, you can actually send their heart into a lethal dysrhythmia. So keep that in mind that we want to be very gentle with hypothermic patients. There is the old quote out there that says you're not dead until you're warm and dead. And that is somewhat true because someone who is very hypothermic can just have very, very depressed vital signs and they can be mistaken for being dead. So we need to resuscitate them until their core body temperature is warmed up to the point where we'd be able to check to see if they have any palpable or discernible vital signs. Like I said, you have to be incredibly careful with hypothermic patients. Any rough handling can trigger them to go into a lethal cardiac rhythm change. So going into the localized cold injuries that we mentioned before, localized cold injuries are what most people refer to as frostbite. So frostbite, if you think about when you were a kid and you got frostbite commonly if you're playing outside, where do we normally get frostbite? It's in exposed areas and it's in areas of very thin skin. So we have most commonly the ears, the nose, the face, hands, fingers, and feet. All exposed areas and areas that we have very, very thin skin. When tissues freeze, they can form ice crystals, and that is very dangerous. So we do have 3 different forms of frostbite. You have early/superficial frostbite, which is actually called frost nip. The standard treatment for that is you remove from the cold and you cover it up. And we're going to show you examples of all these in the next slide. You then have late or deep frostbite. And our treatment for that is to cover and immobilize gently. So right here on the left side, this redness right here, this is frost nip. So again, our treatment is get them out of the cold and cover them up. They should return to normal. Then you have early frostbite. You can see it starting to turn blue and possibly a little black, but normally blue. This is where we might have to do some active rewarming if the patient qualifies for it. And then here we have deep frostbite. So this is where the skin turns bluish gray, black, it's splotchy. This is where we have complete loss of function of the extremity or the affected parts, and this is where we might need to do active rewarming again if the patient meets the criteria for it. Right, moving on into heat emergencies. So if we get excess heat and we can't get it out of our body, we can become hyperthermic. So hyper means high and thermia is temperature, so high temperature. Just like hypothermia was low, hyper is high. If we do not fix this, it can lead to death. Most of the time, heat-related emergencies, if you take the patient out of the source of the heat, will go away on their own. There are two different main things that we're going to need to cover with heat-related emergencies. You have heat exhaustion, also called heat cramps sometimes, and then heat stroke. The biggest difference that we're going to see between the two of these is heat exhaustion, which is the first stage. You'll have moist, pale, normal to cool skin. And then heat stroke, that's when you have the change to hot, dry, and maybe possibly moist skin, but it's really usually hot, red, and dry. So the first stage, as we just said, is heat exhaustion. This is where your body still can compensate. This is why we see the cool, clammy skin, because your body is still trying to sweat off and lower your body temperature via the sweat. As you continue to sweat, your body will lose the proper electrolyte balances in your muscles, because sweat carries a lot of salts. So if you lose those levels of salts, you're going to have cramps in your muscles. This is what we call heat cramps sometimes. This also can cause dehydration just because of the amount of fluid that your body is sweating out. If you aren't actively drinking to replace that fluid, then you can become dehydrated very, very, very quickly. This can happen to very healthy individuals who are just not used to heat environments. This is something that people will see a lot if they live in New York and it's February, and then they go and they visit Arizona and it's 80 degrees instead of 20 degrees, and they spend all day outside. Their body is just not acclimated to that type of temperature, and so they're going to go into heat exhaustion a lot quicker than someone who lives there year-round. So some symptoms that we see, as we said before, we have the pale, cool, clammy skin. That is the telltale sign of being in heat exhaustion versus heat stroke. You do need to know the difference between the two of those. As we said, muscular cramps. You'll have weakness, exhaustion, rapid, shallow breathing as an attempt to compensate to get the heat out via breathing it. You might have a weak, rapid pulse, and that could be a sign that the patient's going into hypovolemic shock. You will have heavy perspiration, and then near the end you have a lot of dizziness as well as nausea and vomiting. Patient care for heat exhaustion is get them out of the hot environment, get their clothing off them so that their body can sweat better, lay them supine, let them have small sips of water to replace the water that they're sweating out, and then apply moist towels and ice packs over the neck, groin, armpits. Just like when we were talking about hypothermia, those are the places that we have a lot of blood circulation, so we can do the most effective change to body temperature if we target those areas, the neck, groin, and armpits. Just for hyperthermia, we want cool, moist towels and possibly ice packs in those areas. So heat stroke. Heat stroke is what happens if we do not treat heat exhaustion and we leave the patient in the hot environment. And again, the telltale sign for the change is going to hot and dry skin. This is also where you're going to have mentation changes. So they are going to be very confused, very dizzy. They might even become unconscious. So that is another sign that we're looking for a change into heat stroke, is the strong mental status changes. You're also going to see rapid, shallow breathing. You should have a rapid pulse, generalized weakness, no perspiration, possibly dilated pupils. They will eventually go into seizures, because if your body's temperature goes too high, your brain will seize. That's why we see febrile seizures in pediatrics, and it can lead to death. As far as patient care goes, you need to get them out of the hot environment, remove their clothing, apply cool packs in neck, groin, and armpit, administer oxygen, transport immediately, and treat their ABCs as you see fit. So General patient care is about the same between heat stroke and heat exhaustion. It's just if they get to heat stroke, they are much more critical. Sometimes with heat exhaustion patients, we get them out of the environment, we give them sips of water, and we might not have to transport them to the hospital if they stay in the cool environment for too long. Once you get to heat stroke, these patients need to go to the hospital. Moving into water-related emergencies. So there's a ton of water-related emergencies out there, usually caused by what you're seeing here. So as far as boating goes, you might have collisions, you might have propellers that will go into humans, and you might have ejections from the actual watercraft. This is especially prominent in jet skis. So with the ejection. So that's some of the traumatic things that we might see. You have several different accidents that can happen with swimming, whether that's a diving problem, which is listed a little bit lower, or could just straight up drowning. Also, water sports can cause a lot of traumatic injuries, such as musculoskeletal trauma, especially if they fall during a water sport. And you can have diving and scuba diving injuries, which we'll talk about specifically later. So some things that we need to look out for when we have a water-related emergency. Biggest thing is airway. Did they take water into their airway? Is their airway obstructed at all? If that's the case, it could easily lead to cardiac arrest. If you have someone who is a little too old for all the excitement that happens in the water, you might have an acute myocardial infarction happen. Injuries to the head and neck are very common, especially in swimming pools. You might have generalized cooling or hypothermia, especially in non-peak summer times. So if it's early summer or early fall, you will very likely have hypothermic problems because the water temperature is just simply too cold. Heat-related emergencies are especially profound, especially in the middle of summer, mainly because people will stay out on the lake for hours and hours and hours on end and not realize how much that they're sweating and how hot they're getting, and then all of a sudden they find themselves in heat exhaustion or heat stroke. Substance abuse is very common, whether that's alcohol or drugs. That's very, very common around bodies of water. And then the obvious drownings. As far as patient care goes, remember, scene safety. That is, if you compromise yourself to try to rescue someone, you're no good to them, and then you become a patient yourself. If you're not trained to go into the water to get someone, don't go in the water. There's a reason why lifeguards are specifically trained to do this. Drowning patients are unpredictable. They will try to cling on to anything to make it so that they can get above water. That includes you if you approach them. They will not have a rational thought to accept your help. They will just try to climb up on top of you to get out of the water. So if you're not trained to go do that, you can drown yourself easily. There is the saying of reach, throw, row, go. That's the order of how you can safely get someone out of the water. Preferably, if you can reach them from shore, then reach and grab them and pull them up. If you can't, then you try to throw a device to them, especially a life ring that's on a rope. If you can throw that to them, they can grab onto it, then you pull the rope in, that will pull the patient in. Next is row, which means bring a vessel out to them. So you can bring a vessel until you're within reaching distance and reach and get them in there. And then last is go yourself to go get the victim. And again, if you're not trained to actually go do that, so if you have not gone through lifeguard training, do not enter the water and try to go get them. You will very easily become a patient yourself if you do that. So talking about drowning, it is relatively common to have happen. There's around 4,000 drownings every year in the U.S. Typically seen in pediatric patients, but it can span ages of all ages. The last drowning I did was to a 40s female. It was in a hotel pool. So it can happen to anyone. There are two different types of drownings that we talk about. We have wet or dry drownings. Dry drownings means that the water does not enter the lungs. And this is because we have what's called a laryngospasm happen a lot of times. A laryngospasm is when your vocal cords will spasm and slam shut, and that will not allow any water to actually get into your trachea. It's going to bounce off and go to your esophagus. So typically, most people who are drowning will not have water enter their lungs until just before death. That's one of their last attempts to breathe, is when their laryngospasm will relax, and that's when water actually enters their lungs. So dry drowning is when the spasm does not relax and you never get water entering your lungs, and a wet drowning is when your water actually does enter the lungs. If you have a patient who is drowned and you're ventilating them, do positive pressure ventilations. It might be harder to get ventilations in there, so you might have a lot more resistance, and that's because there might be water in the airway that you're trying to push through. Be prepared to suction a lot of that water out, especially once you start ventilations. The water might come back out at you, so be aware of that and be ready to suction. Again, you probably are going to have to be a little bit more forceful than most patients, just because you have all that water you're trying to ventilate through. If you have a possible spinal injury in the water, a lot of times spinal injuries have to be assumed. And so if you have anyone who is unconscious in the water, assume that they are unconscious because they have some sort of head or neck or spinal injury. This is very common if you see anyone in a controlled environment that's unconscious, such as a pool area. Generally, that's going to be caused from a diving injury in which they injured their head, neck, or back. So keep that in mind. You shouldn't withhold resuscitation to immobilize the neck and spine. If they need resuscitation, go ahead and do that immediately. Doesn't matter how well you immobilize the spine if you don't have a patient. So keep that in mind, that your ABCs do come above trying to immobilize someone. It is also very hard to fully immobilize someone while they're still in the water. Some lifeguards are trained to try to do that, but it's acceptable to get the patient out of the water first, treat them, and then immobilize them. Like was just said, patient does need their ABCs to live, and when possible, keep a patient's neck rigid and in a straight line with the body's midline. So general treatment that we would do for head, neck, or back injuries. So diving accidents typically happen when you're diving into a shallow end of a pool. And so the most common form is a head, neck, or back injury, and it's usually from an axial load injury. It's when you dive head first, your head hits the cement of the bottom of the pool and your spine compresses. So that causes an axial load injury. Go back to the head, neck, and back injuries and lecture, and we'll talk all about treating that. So as far as our emergency care, it's the same thing you would do with anyone else with a head, neck, or back problem. So treat them just like you would for a patient who is out of the water. When it comes to scuba diving, there's a couple things that we need to keep in mind, and scuba divers themselves should be mindful of this themselves. They should be aware of all this, and they take steps to mitigate this so it doesn't happen to them. So the biggest thing that we need to watch out for is something called decompression sickness. So when someone dives, especially scuba divers who go down very deep, they are under immense amounts of water pressure. The further you go, the more water pressure you have. So when they come back up, they start to decompress because they don't have as much water pressure pushing on them. That's fine, except when we go down, our blood gets compressed too. And all the gases inside our bloodstream get compressed. So if you come back up too fast, you're going to expand all the gases in your blood a little bit too quickly, and that's going to cause a lot of the issues we see in decompression sickness. And it's typically caused by a gas called nitrogen, which is in your blood. And when you compress nitrogen, it actually will dissolve in your blood So it gets dissolved during the dive. Then when you come back up, it's going to start expanding and not be dissolved anymore, and it causes bubbles inside of the bloodstream. This usually for symptoms takes 1 to 48 hours to appear, so it's not immediate. This is why we see it as EMS providers, and we have to be aware of the signs and symptoms, because we have to see what someone's complaining of who's calling from their home that's nowhere near a body of water, and then try to put 2 and 2 together of, oh, well, they went scuba diving a day ago. Like I said, most scuba divers receive training about how to mitigate for this and how to take precautions for this, but it can happen if you are not adequately trained. It can happen if you have an equipment failure and you have to make a rapid descent because you can no longer breathe down there. So any sort of underwater emergency is the same principle. Or if they were just simply trying to conserve air and just push themselves too fast. So some signs and symptoms of the air embolism is numbness and tingling sensations in the extremities. You might have some generalized or specific weakness, possible paralysis, but that's pretty rare, frothy blood in the mouth or nose, and possibly seizures. With air embolisms, you can have a patient go suddenly unconscious on you, and you can have them go into respiratory and cardiac arrest. Air embolisms are not anything to mess around with. So these are patients that should get an ALS evaluation just because they can change very quickly on you. Other things that we look for with decompression sickness is they really kind of look like they're intoxicated. You'll have altered mentation, they'll be fatigued, they're going to stumble around, they might have some chest pain, and one of the biggest telltale signs is having very deep pain in the muscles and the joints. That's referred to as the bends, and that's something that any scuba diver should be able to recognize because they are trained on signs and symptoms of the bends. As far as taking care of these patients, general treatments for anything that we would encounter. So if you have a compromise of the ABCs, treat the ABCs, rapidly transport them, and if you have a hyperbaric chamber close to you, then transport them to a hyperbaric chamber. Hyperbaric chamber you can change pressures inside of, so they can start to put more pressure into the body and then slowly release the pressure so that it's just like if they came up out of the water at the right rate. So hyperbaric chambers are a great way to treat these patients. They are relatively rare in the Syracuse area. There's only one hospital that currently has a hyperbaric chamber, and that is upstate. When we talk about ice rescues, seeing safety, seeing safety, seeing safety. If the ice was thin enough to have a patient fall through, it's thin enough for you to fall through. This is stuff that you probably shouldn't be doing the rescuing unless you're part of a fire department and get separate training on how to do the rescue. If for some reason you're by yourself, try to throw a flotation device to the patient, try to throw a rope to the patient so you can pull them. And if you have one available, have a flat or a flattened bottomed aluminum boat, because that can withstand having ice break underneath it, and also it disperses the weight across the boat very evenly. So aluminum boats with flat bottoms are great vehicles used for ice rescues. If you don't have one of those available, laying a ladder flat on the ice does a similar job of distributing the weight a little bit better, and you can try to pull the patient out with the end of the ladder. If you can extend the ladder out to them, they might be able to grab onto it, then you can pull the patient towards safety. Once you have the patient out of the water, treat them for hypothermia. Keep in mind that the patient is probably going to be very hypothermic, so they're probably going to not be able to have great motor control at that point. Transport the patient, and remember, do not work alone or walk out onto the ice unless if you're specifically trained to be on the ice. Right, going into altitude-related illnesses. Biggest thing that we need to talk about is altitude sickness. So it's pretty common knowledge that if you are in a high altitude area, there's a lower concentration of oxygen. This is, when I say high altitude area, I mean high. Usually you don't start to see altitude sickness until you're at least 8,000 feet above sea level. This does change per person, but that's generally the rule of thumb of most people will be fine until you get about 8,000 feet above sea level. There's not too many places in the New York State area where you get 8,000 feet above sea level. There might not be any, I'm not sure. I'm not an expert on geography of the state, but there might not be any places where you get that high up. Typically, symptoms will start within a few hours after arriving at the high altitude, and it usually will go away either once you become acclimated to the high altitude or when you get out of the high altitude environment. If you become acclimated to it, it usually takes a couple days. So the signs and symptoms that we look for with altitude sickness, it's very similar to an alcohol hangover. So the biggest thing is a headache. You might have fatigue, loss of appetite, nausea and vomiting, but the headache is the biggest thing that we look for. So if you know that the patient is either in a high altitude area or just returned from a high altitude area and they're complaining of a severe headache, chances are it's probably being caused from the altitude sickness. Treatment is, again, primarily get them to a lower altitude and their symptoms should resolve, but we can give them oxygen. Oxygen will help relieve the symptoms because they're having them from a lack of oxygen, just because the oxygen concentration is lower at higher altitudes. So if we give oxygen, it should fix the problem. All right, going into bites and stings. We'll start with spiders. All spiders are technically venomous. Now, whether they are fatal to humans, not many in the Northeast United States are. New York State, where I'm talking from, there's not many venomous spiders around. And most of the ones that can cause harm are actually not native to Northeast United States. So insect stings and bites are rarely dangerous unless if the patient goes into anaphylaxis. That's a separate issue, and we already talked about allergic reactions and anaphylaxis, so if you don't remember how to treat anaphylaxis, feel free to look up that chapter. We might be called just because someone got stung, so we do need to know how to do stinger removal and a few other insect removal techniques. So as far as stinger removal goes, we need to scrape it off the skin with a hard-edged item. Credit cards work great for this. We do not use tweezers because if you use tweezers and you squeeze the stinger, you can inadvertently squeeze more of the venom into the patient. So we are not using squeezers, we are just rubbing the skin with a credit card or any hard-edged item until the stinger comes out. If you have a tick that has embedded themselves in a patient, you can remove the tick. This time you can use tweezers. You grab the tick as close as you can to the body and you pull it straight out. Once you've pulled it out, you can put it into a plastic sealable bag and dispose of it. But most importantly, do not crush the tick in your fingers. That can cause some of the diseases that the tick carries to go to you. So tweezers for ticks, no tweezers for stingers. Leeches. Leeches are still very common, especially in creeks, and they are in New York State. I got a leech attached to me relatively recently. I was going around in a creek looking for crayfish because I'm a child at heart, and I came out and there was a nice little leech attached to my ankle. So leeches, they attach to the skin and they suck blood. They oftentimes go undetected because when they bite you, they inject anesthetic and anticoagulants into the bite wound. So the anesthetic is gonna make it so you don't feel anything, and then the anticoagulant makes it so that you bleed a lot more so that they can suck the blood easier and doesn't clot off. They will bury their head inside of your body to feed on you. When they are done feeding, they will naturally detach. So that's why they oftentimes go undetected, because when they're full, they detach, they go on their merry way. If you do remove a leech, never ever ever squeeze the leech to remove it. If you squeeze it, you can cause the leech to regurgitate inside of the patient's body. Depending on what they've attached to, that means that you might be regurgitating another person or animal's blood into the patient's body, something we kind of want to avoid. So if you need a leech to detach, go ahead and immerse them in salt water, and they will eventually release because they can't breathe through the salt water. So they'll release to try to get out. As far as spiders go, like it said, all spiders are venomous. Not many of them are native to the United States. Northeast United States, sorry. Two that we do see a little bit in the Northeast United States are brown recluse and black widow spiders. Again, they're not native to New York. They prefer warm climates, but they do appear in New York State. They're just not very plentiful. They can have life-threatening symptoms. It's usually not immediate, though. This is if you leave it untreated for days on end. As far as the symptoms of spider bites, you're going to see pain, swelling, tenderness. If it's a very venomous spider, you might see nausea and vomiting. You might have some difficulty breathing. You might have muscle cramping, and then eventually tissue necrosis. Again, this usually takes a while to actually occur. So these are bites that have to be left untreated for a very long time, typically. Right here is a picture of a brown recluse bite, and you can see at the bottom it says day 4. So this is tissue necrosis. This is also 4 days into this event. So this doesn't happen immediately. This is a slower progression, but you can see there is obvious tissue necrosis there. If you have it's probably going to be a non-native spider, so something that's been exported to New York State that's severely venomous. They can produce an altered state of awareness, blotchy skin, numbness in an entire limb or body part, heavy burning sensations followed by pain spreading throughout the limb, weakness, difficulty breathing, and an abnormal pulse rate. Again, this is very rare to see. This would typically be like if it was a person's pet that bit them. The biggest thing that we need to be concerned about with most spiders is anaphylaxis. Most people don't have an anaphylactic reaction to spiders, but it can happen. As far as patient care goes for spider bites, treat the signs and symptoms, remove the stinger if applicable, and remove jewelry just in case if it does become inflamed. You want to have the jewelry off before the area becomes inflamed and you can't physically get the jewelry off anymore. Going into snake bites. So not every snake is venomous. Unlike spiders, every spider is venomous. Not every snake is venomous. Most snakes in New York State are not venomous. That being said, people tend to keep snakes as pets, so there are snakes in the state in people's homes that are very venomous. So we do have to be aware of this stuff. This is one of those sections where when I was in EMT class, I'm like, when am I ever going to treat a snake bite that matters? Well, people keep weird things in their houses. So keep that in mind that we can absolutely go to a snake bite. So if you have a snake bite, they do require special care at the hospital typically, but usually they're not life-threatening. Even if you have a venomous snake, they're typically not life-threatening for humans. The biggest thing that can kill a human is anaphylactic shock. Beyond that, death is not all too common. So that being said, you have to keep the patient calm. If they were bit by a rattlesnake, they're probably going to think that they're going to die. Keep them calm, reassure them, and keep them at rest and transport to the hospital. It's very rare for someone to die from a rattlesnake bite. Speaking of rattlesnakes, we'll talk about pit vipers really quick because rattlesnakes do fall into the pit viper category. Typically, as a general rule of thumb, any venomous or dangerous snake to humans will have a triangular pointed head. That's the telltale sign that a snake is venomous, is a triangular pointed head. Typically, pit vipers are not aggressive. They hide. They don't want to be near people. They don't want to be near anything, so they have their own little area. They can become possessive of their territory, though. So that's usually when we have an issue, is when someone walks straight into their territory a couple feet away from them, they might strike at that point. Approximately a third of their bites don't actually contain any venom. So 1 in 3 times they're shooting a blank when they bite someone. And of the ones that contain venom, only 1 in 600 are fatal. The reason behind this is people get immediate treatment. The fastest lethality snake bite is 20 minutes, and that's from a black mamba, but most pit vipers take 2 to 3 days to kill someone. So that's why only 1 in 600 are fatal, because most of the time we have time to get them to the hospital and get anti-venom to treat them. There aren't many black mambas in this area, so the chances of you running into a pit viper that will kill a patient before you get to the hospital are incredibly slim. Here's a picture of a pit viper. This is a rattlesnake, and if you can see his head right here, see how that's a nice triangle and pointed head? So that's that telltale sign that that is a venomous snake. So if you do have viper venom injected in the patient, it does cause destruction of capillary walls. Some can cause the blood to coagulate very easily, or some might make it so that the blood doesn't coagulate at all. Depends on what type of viper bit you. It then eventually does cause tissue necrosis, and if left untreated, this will cause death. As far as patient assessment and care goes, you need to look for a noticeable bite on the skin. A lot of times the fangs are needle sharp and needle sized. So a lot of times it might just be a little bit of discoloration on the skin. Typically a patient will say, a snake came out and bit me. Especially in New York State, they probably knew that they were handling a snake at the time. You will probably see pain and swelling in the area of the bite. It might be slow to develop though, so don't just say, oh, you weren't bitten because you don't have any pain to that area. It can take some time to develop. You might see a rapid pulse and labored breathing. You might see progressive general weakness, some vision problems, nausea and vomiting, and at the late stages, altermentation, seizures, drowsiness, and then going into unconsciousness. As far as patient care goes, one of the most important things that you can do is try to take a picture of the snake if it's still present. That will help identify what species it is. If the patient doesn't know exactly what species it is, this is very, very helpful for the hospital to try to identify to get the right antivenom. Transport the patient immediately and advise the hospital so that they can start to work on acquiring that. In New York State, there's not many uses for antivenom, so it might take a while to get antivenom to you. Treat for shock and any other symptoms if needed. Remove any jewelry, just like we talked about with swelling. Keep any bitten extremities immobilized. And then do not use a tourniquet, suction devices, or try to make incisions to the area to drain the venom out. We are not to do that. That will make things so much worse. So keep all that in mind. So poisoning from marine life can happen in usually 2 ways. One is on land, eating improperly prepared seafood, especially sushi, if you're using a poisonous fish. So that's one way that you can have an issue with marine life. The other one is stings, punctures, or bites from marine life. Typically, if there is a toxin from marine life, fresh water will actually activate the toxin, which will increase pain. So if you are rinsing an affected area where someone got some sort of puncture or sting or any sort of toxin from marine life on them, try to use salt water to rinse that area. Again, New York State, we don't have that big a issue with marine life trying to come after us, but it is something you want to keep in mind. So moving into some chapter review. Remember, heat is lost and gained through convection, conduction, evaporation, respiration, and radiation. Certain illnesses, medications, and underlying conditions make patients more susceptible to heat and cold injuries. Remember, providers should never attempt a water rescue, unless they've been properly trained to do so. Remember, two special problems seen in scuba diving accidents are arterial gas emboli and decompression sickness. Some questions to consider is the scene safe from heat, cold, or venomous creatures? How can I get the patient from the water safely? For hypothermia, does the patient have altered mentation? For hyperthermia, is the patient's temperature cool to normal or hot? So you're with your family at a local lake. You observe a boat capsize near the middle of the lake. Screams can be heard from the scene. You are a marginal swimmer. Several civilians begin swimming out to the site. Apply concepts learned in the scene, size up to this scene. So, biggest thing is scene safety. If you can't get to the patient because you're a marginal swimmer, you should not go to the patient. You should have someone who's trained in water rescue go get your patient for you and then bring them to you. Hopefully with a capsized boat there are no injuries. Oftentimes there's not, but if there are, then you just follow your general treatment once the patient is to you safely on land. That brings us to the end of this chapter. Like I said at the start, there is a lot of stuff that, in terms of New York State, you don't see all too much, but we have to definitely be aware of it because it can all happen, and when it does, you're expected to be an expert in this stuff. I know you can't be an expert with 52 minutes of me talking to you about it, but you need to have a good general basis knowledge as to what to do if you see any of these things happen. So, until next time.